尔雅格激光辅助一钻植牙的临床秘技大公开。讲题大纲：一、一钻植牙设计的原理；二、一钻植牙的临床应用原则；三、激光辅助即拔即植的一钻植牙流程。陈俊龙院长的讲学经历：美国哈佛大学牙科医学博士，全额奖学金榜首毕业；美国西北大学奖学金牙周病植牙专科及硕士毕业；美国哈佛大学牙医学院董事；美国 GICD 总编辑；美国拉斯维加斯牙医学中心院长；台北里昂哈佛仁爱诊所助诊。下面请我们的陈俊龙院长演讲，谢谢。
请陈俊龙院长为我们讲解以下的讲题。
Can I start it? Yes.
Okay, perfect.
Hello. Yes.
欢迎我们的陈俊龙院长。
Okay. Anyway, about 3 days ago, the academy asked me to speak in English, so I guess I have to switch to English mode now. I know everybody's very tired. This is a last lecture of this 2 days lecture. I'll try to make it quick and try to share with my happy implant journey. By the way, I'm Dr. Liang Chen. I guess we are now we only can exchange with voices. Actually, I'm a very funny guy. One day we can see me. In this pandemic period, I just hope everyone stays safe and wish everyone an early happy Halloween and also happy Thanksgiving and Merry Christmas. For some of the doctors not familiar with me, I graduated from Harvard back in '93. Went to specialize in periodontics and master in science at Northwestern University in Chicago. After Chicago, I went to Las Vegas starting my practice. Within 3 years, I opened 6 dental offices. In 1998, I bought a Circus Hotel Casino VIP clubhouse. I turned it into an implant training center called Dental Implant Institute of Las Vegas. Some of you may question in this past 4 or 5 years why I am in Taiwan most of the time. Many reasons, but one of the major reasons is to take care of my 100-year-old mom. It's very funny. She's 100-year-old now. Well, actually, after October 10th, she's 101. And the other day, she asked me she wants a boyfriend. Anyway, right below is my email. For some of you like to get in touch with me, you're welcome to do so. Without further delay, let's get started. Today's topic is laser-assisted one-drill implant. We have a 6 subtitle here. We began with an introduction of what is one-drill implant. What is the first? This is the first true one-of-its-kind one-drill implant system in the world. The term one-drill implant means the first drill, first initial drill is also the last drill. Then the second drill is the final drill and also is the implant itself. The second point is the step locking concept. The core technology of this osteofused one-drill system is the patented step locking concept. We will go further depth in this concept later. 3, primary stability. So with the step locking concept giving the implant in most situations and over 25 Newton centimeter primary stability. Having a maximum primary stability, will that possible encourage us to do more immediate implants? And 4, were I able to place implants in a more ideal position and angulation? What else? What else are we concerning of immediate implants besides stability, position, and angulation? I believe are the cross-contamination and infection. Do we agree? I can't see anybody here, so I only look at the screen. So I guess people probably agree with me here. So let's go into our fifth point here. So if the entire osteofused one implant surgery require only one drill, are we then able to discard the drill to stop the cross-contamination? Since the drill is brand new and the drill cutting blade are at its sharpest every time, so are we possibly preventing the overheating? So number 6, last and not the least here, infection is infection in a localized extraction socket. With the usage of a spoon excavators, we are not 100% guaranteed to remove all the granulation tissues and disease tissues. So only way we can get close to a 99.9% clean is in conjunction with the Erbium laser. So this is one of my lecture, one full-day lecture. But today we're gonna touch one drill here, a little bit of angulation, and a little bit of implant failure, okay? So what's one drill? I'll just quickly translate this. Many doctors ask me questions. It is frequently asked, why some implant system takes 4 drills in order to place 1 implant, when some company takes 10 drills to place an implant. Really, I really don't know. I have no answer for that. Some doctor ask why some drill are very easy to perform osteotomy, and some are hard to do osteotomy. Osteotomy, I'm sorry. I really don't know. Some drill are easy to do and some are not. And some drills bounce around so much. Why is that? And also sometimes the drill has the markings, and those markings are hard to see when patient is bleeding, saliva, water, smog. I say fog, foggy. So it's hard to see those markings on the drill. So now, how about when the drills are dull? And when the drills are dull, I can't really tell what's from the D1 to D4. Oh, yeah, I guess many times the company suggests that we sterilize for 20 times and we should throw that drill away. How many of you, maybe I should ask myself, I don't keep track of it. And I tell my assistant to keep track of it 20 times. I don't think they do. Many times how we find out the drill is dull is during the middle of surgery. I realize this drill is dull. Then what I do is I whisper to my assistant without patient hearing it and tell my assistant next time, can you throw this away and put a new one in? My assistant probably will nod her head, and later she probably re-sterilize it again and give it to me the next time. So that happens many times. Now, how about the how we prevent the overheating? Well, not just by drilling slowly. There's many other issues involved. So last, many doctors ask me, why the same company, I'm not talking about different company, same company with different line. For example, I use the 2-piece implants, and then later I want to change to 1-piece or zirconia implant. I have to use a completely new surgical set. I don't know why. And sometimes when we come to we wanted to start with a surgical guide surgery, we need to buy another surgical set. So I really don't know why is that. What can everything be one set? So let's talk about osteofuse one drill. This is truly one drill, but people think of a one drill, they think of a mini implant. Some people think of one drill as a mini implant. Yes, mini implant usually looks like toothpicks. It's one drill and then the implant goes in. That's simple as that. But can we do mini implant? The time that we perform mini implant, but we did a regular implant. I think most doctor and patient would like that. If we can do this mini implant in 10 minutes, why can't we do one drill regular implant in 10 minutes? So this invention, I had a patent back in 2012. And then in 2015, I went on the tournament to the competition tournament. I took a first place in the medical category, and this is a one drill system. And they gave me a $3,000 check. It's pretty much, it gave me a little encouragement. See, here you are, here's the one drill and implant. Many doctors ask, how about the bone density? And actually bone density is not even an issue. From the D1 to D4 bone is not even an issue. As long as you follow the surgical protocol, actually there's still one drill. Doesn't matter how wide the implant should be. Now this drill has a stopper. This stopper is pretty much a safeguard, so it doesn't matter how hard, how far we push down, it will stop right there, and then implant will be placed following. So, but looking at traditional system here, we have first drill to a purchase point, and second drill is the initial drill, and then we have a guide pen, then get wider, another guide pen. Many times another guide pen, the second guide pen usually wobbly a lot, but that's just the way it is. Then we do the countersink and tap an implant. Well, what is one drill really? Just a drill, a step drill. These are multiple 5 steps. One drill, and we go into the final drill, which is implant. So by the time this patient goes to the second stage, when we're switching the drill, going to the second, we finish this implant here. So many people may question why. Why is it something that you went very aggressive on it, or you went really fast on the drills? No, actually, that if you might look at it, this is initial drill, second, third, fourth countersink. I'm just giving an example. First, second, third, fourth drill. If we turn it around, does it look like a step drill? Let's look at it. First drill, second, third, fourth. I did not skip anything. But if we just looking at it, my very first drill is a step. My second step is my third step, my fourth step. So pretty much that is exactly what a one drill look like. So if we're looking at it as we slowly, step by step, take our time. We don't need to look at the depth anymore. We just look at the angulation because the depth is predetermined. And as the next doctor, the other doctor switching one step to second step, they're wasting a lot of time during the surgery by switching all the drills. Here we are just one drill, and we just go step by step slowly. And then the second drill is the implant. So this is osteofuse one drill and second drill. As you're looking at it, the initial drill here, you will bounce a little bit. Any drill goes to cortical, you will bounce a little bit. But once you pass the cortical, it acts like a drill guide. Then here comes our second step, which is second drill, third step, third drill, fourth step, fourth drill, countersink, and stops right here. So if you look at this drill, it has all the steps on the side. The steps will give us a cutting capability, side cutting capability. What that means is when we decide to change the angle a little bit, we can with this drill. Many doctors ask, oh my God, doing one drill, what if I place it in the wrong angle? Yes, we can correct it right there with the drill. Then also we can correct the angle with the implant itself. So let me show you this. This is a funny case, but I have nothing to challenge anyone. I just want to maybe wake up some people. This is me when I was young, back in 1991. I took the Straumann course. Funny thing is, this is a Straumann instrument, Straumann set, but it's a Nobel drill and a Nobel motor and Nobel handpiece. But anyway, that's not my point. My point is right here. Back in 1991, what am I looking at? I'm looking at the drill marking and drill angulation carefully, very carefully. Look at my neck, look at my shoulders, look at my back. I'm concentrating so hard just placing that one implant. Now, looking at that time, we do not have a cell phone. At that time, we only have a beeper. In Taiwan, we call it BB call. So now in 2021, we have iPhone. The iPhone can see movie, can take pictures, can transfer account, and also can make phone calls and text. But this is my son. What is he looking at? He's looking at the same thing, markings and angulations. What is my daughter looking at? Same thing. They're going to hurt their neck and shoulders eventually. And what's the motor? Looks the same what I have. Looks at the surgical instruments, look the same what I had. 30 years later, what are we doing here? We're doing the same thing. Initial training. Are we not changing much anymore? The world has changed in 30 years. This is my number 6 daughter, 6 years old. I gave her a osteofuse one drill. I asked her just to look at a footpath and then drill whatever you want. Treat it like a toy. She drilled pretty much in 8 seconds. She make a ostectomy. I changed out the drill and gave her the implant. She pretty much playing around, but is she really concentrating much? No, she just kind of placed that implant in. She stepped on the footpath and inserted a toy. To her, it's a toy, but actually should finish an implant. I'm not trying to insult anyone that we are less than 6 years old. No, I'm not. I'm trying to say that as myself, you know, my back, my shoulders, my neck, my eyes. As I getting older, I'm deteriorating. I can't see much, but I can see those lines, those markings. But at least I can see the angle. So if we make the instruments much easier to do, just like what my 6 years old daughter did, then I guess implants much easier to perform. So she did 5 osteotomy, osteotomy 5, or to her is 5 holes. Here is one drill. This drill, we call it just a one-time use. So what that means, we can re-sterilize it, but anyway, when next time we order another set of implants, it comes with another new set of drill. So this drill, after one use, goes to trash can. This implant goes to the patient's mouth. This instrument, we call it fixture deliver. It goes to the sterilization room. So pretty much we perform one implant, simply a simple instrument, and not many tools involved. So let's go to a step by step here, because this is our first drill, which is first step, second drill, second step, third, fourth, and stops right here. Next thing we change out is implant. An implant placed 3 months later, final restoration. So I picked a very easy case to kind of share with everyone. I'm not trying to rush this. This video is not editing at all. And everybody look at the timer, and we even include that we're changing out the implant itself. I'm not trying to say that we need to rush these surgeries. I'm trying to say that we can lessen the tool, and then we can make things simplified. But many doctors may question, well, one drill. I never heard of one drill. But let's think. Many times a company will do 12 times, just change out 12 drills to place one implant. Some company has 10, so we're getting less and less. Some company has 4, change out 4 drills in order to place one implant. So the many company, the direction is we are going to less and less drills. So if we look at 2 years ago in Madrid, Nobel came out with a 2 drill system, 1, 2, an implant. Well, this first drill, it looks like the same drill that we always have. Now here comes another drill, which is looks pretty aggressive. From a cylinder shape right here to something not just changing the shape, changing the size, to very aggressive looking, and then implant. Why are we going to that direction? That means we are going to a less and less tool. So now Nobel come up with 1, 2 punch and then implant. Straumann come up with instead of let's look at this 2 huge companies. There's a big company here. What's a common denominators here? The common denominators here is aggressiveness of the final drill or the aggressiveness of the implant itself. Why so aggressive? I thought in 30 years ago, they say they have to be conservative. They have to go slow, one step by step. Why are they going too aggressive here? I know the reason, because for stability. Everybody is trying to reach primary stability now. So is osteofuse step locking very aggressive? No, not at all. Let me explain to you. This is what we're going to go into the second step and then a third. Let me go into this. This is a gradual step here. 1, 2, 3, 4, 5. Osteotomy here. Then let's look at the implant. Implant has outer body and an inner body. Okay. When we talk about compression necrosis, we're talking about the implant, solid part of the implant compressed on the bone. That will cause necrosis. So let's look at it. The inner body, which is the solid core part of the implant, do not touch any part of the bone at all. The step drill gives a over drill and an under drill. Okay. And since the inner body do not touch the bone, so how this implant gonna be stabilized by it? Well, if we look at the outer body is a thread through thread. And look at carefully, the under drill part, the thread will shave off the autogenous bone and push it to the over drill part. And the over drill area will be, it's a pressure release area too. So therefore, in every step, we're gonna get some locking there. So therefore, we can reach a very high primary stability. Let's look at this case. This molar area, actually, it's the immediate extraction, immediate implant. And everybody knows, number 6, first molar usually a huge socket. We're able to place the implants and reach the maximum over 80 Newton centimeter. Well, in that case, we can go ahead and temporize a fixed temporary here. So some doctor may ask, we're going to number 4th point. Some doctor may ask, well, what if my first punch was wrong angle? What can I do? What if there's a knife edge? What are we going to do with knife edge? Normally with a knife edge, if we go straight down, usually the drill bounce around. So I would suggest we go from the side. You can see on the practice here. Instead of going from the straight down, we're going from the side, let's say buckle. And then once second step going to the bone, then we start redirecting the angle and change to the ideal position. How about the L-shaped bone? With L-shaped bone means there's a palatal bone and there's no buccal bone at all, and the floor of the base. We're doing the same thing. You have to go through the angle. Go through the off angle. When you go into 1 or 2 steps into the bone, then you start redirecting the drill. Then redirecting to the drill, the ideal angulation we prefer, and then we're done. Okay, so that's how we can do it in the L-shaped bone. Okay, let's look at the clinical. See, the drill bounced around too much. I couldn't get a hold of it. So I will go from the buccal side, go into about 1 or 2 steps. Then I start redirecting the drill. Now I'm redirecting the drill to the ideal angulation, and I will proceed further with it. So that's the drill. Drill can change the angle. How about the implant? Can the implant change the angle? The implant itself can change the angle probably only 15 degrees, but it can change about 3 or 4 times. So normally that's how we can, how we do it during the middle of surgery. We'll change the angle to the ideal angulation and ideal position. So this is a zirconia implant, by Osteofuse, and they call it Z40. This zirconia implant, I placed it in. I realized the implant came out of buccal plate. So then I reversed the implant out, and then redirected a little bit palatally. Now it's a whole entire zirconia implants in the bony housing, just a little bit of fenestration right here. How about the one body implant? The one body implant in this case, I did not like the angulation of this implant. A little bit, just a little bit off. So I like to go toward buccally a little bit. So I reverse the implant out. Then I push a little bit to the buccal side. and I insert the implant in again, redirect it, and once the implant is seated subcrestally, I have patient bite down, and I like the angulation, so then we finish the implant. So now how about two-piece implants? I did not like the middle implants here. The angulation is a little off. Usually I like to give them a good angulation so I can give them a fixed temporary right there. So I back out the implants. This implant actually should have to go a little bit, well, not a little bit more mesially. So I place it and I did not like it at all. So I back it out again, second time, and I place it again. So it still reached more than 30 Newton centimeters. So I was able to redirect this implant into the ideal position and the angulation. Okay, so here we are. This is it's going to be published next year in Compendium. We did a immediate implants right here on the first molar and second molar, and due to the primary stability, we're able to go ahead and put a wide healing. Once we place a wide healing, then we can just fill in with a osseous bio-os around the gap. No suture involved, no needed. 1 week later, as you can appreciate the soft tissues, and then 5 months later, we're done. And this is what the soft tissue look like. Let's go to the other side, same patient. We did a extraction, same day implant, but it reached such a high stability, we go ahead and put a wide diameter healing. I grabbed little bone right here and there to just fill up the gap. No suture needed, and this is 1 week later, and this is about 6 months later. As you can appreciate, the soft tissue did not collapse. We did not do any free gingival graft. It just one surgery, we finished, and then next thing is restoration. Okay, how about the anterior? We talk about this aesthetic zone. This patient, we took 4 teeth out, hopeless teeth. Then we use a erbium laser to clean up the socket really well. 4 implants placed, and they reach a very high primary stability. We then temporize it. 4 or 5 months later, came back for impression. 6 months later, we finished this. The whole thing is just one surgery to here. Second time, no more surgery. It's just impression, or nowadays we call it scanning. This patient came in, actually car accident. Knock off 3 teeth. He came in, we went ahead and took those 3 teeth out, clean out the socket, erbium laser it, then 3 implants placed, temporary, fixed temporary. 5 months later, we finalize it, and here's the final x-ray. So here we are. Can we do implants? When I say walk in, means initial exam. That means a new patient. The patient walk in. I haven't seen this patient. First time I saw this patient, and we'll take a CT. Can we do immediate implants on them in the ideal position? We already I already shared with everyone with a 1 to 4th point. Now we're going to go 5 and 6, but with this 4 points, can we do immediate implants in the walk-in patient? When I ask a lot of doctors about immediate implants, many doctors told me, yeah, I done that, and there's no problem, but only on certain cases. Why only on certain cases? Why not every time? Well, because, I believe everybody knows, because of primary stability. We can reach primary stability, then I cannot do immediate implants at all. Well, the idea of immediate implants, it's been published since 1997. So I don't know why we're not doing that. I don't know why we're not widely doing that almost 99% of the time. Well, I know why, because the primary stability. But the advantage, I won't go through very quickly. Everybody knows the advantage of the immediate implants. Less surgery, less waiting time. Of course, we take the tooth out and place the implant right away. We prevent the bone resorption. Fourth, once we take a tooth out, there's a bleeding point. When we place the implants, we'll stop the bleeding. So if we tell the patient that I can do it in one surgery in one sitting, or we can do takes about a year and a half and 5 surgeries, in between there's 2-3 months of a healing period, I think most patients will choose immediate implant. Agree? Okay, so why are we not widely used immediate implants? I believe there's 3 major concerns. infection, primary stability, and also the angulation. Without these three, we don't need to talk about this. Without these three, there's nothing underneath here. Okay, let's go to another article. I kind of want to point out to most of the doctors, maybe just kind of let most of the doctors realize few things. There's many different implant design. I don't really much concern about that because they are just a non-functional implant design. But many companies study cell biology under surface treatment. Well, I heard about surface treatment from the 4 months integration to 3 months to 2 months and then 6 weeks. I question, can we go more or less to like 1 week? Can somebody come up with 1 week surface treatment? I don't believe that. Why? I think that's a cancer cell surface treatment. So let's look at this classical dip. We know this picture all the time. When we take an implantology 101, there's always the classical dip. So we're talking about in 4 or 5 weeks, we're going to have a huge dip right here. So what are scientists doing? They are doing to shift the secondary stability, which is bone, which is cell biology, to the left side. They try to push this curve to the left. Why? Because then we can have this implant integrated quickly. But hardly anybody talking about the primary stability. If today we push this primary stability to the right, like I'm just drawing here, are we getting a straight line here? If we are getting a straight line here, can we today extract a tooth, place an implant, and final restoration? I think that's the future and that's possible. And I think that's what patient wants. I think that's what I want too as a doctor. Okay, let's look at all the design of implants. So many different designs. They claim their surface area is great. I understand. I believe they are great because they work on it really hard. But they are not really designed for immediate implants. They're designed for delay implants, like the bone grow first. Let's do a bone grab, artificial membrane, ridge augmentation. Then we do the implants. Yes, I understand that. But can we design a immediate implant? Let's look at it. This is just just for study reason, for just like challenging ourselves. This doctor, I'm pretty sure he's a very famous doctor, famous implantologist. I'm pretty sure he does very good in angulation, and he does. Nice angulation. All these are very nice. So let me ask, which one was an immediate implant? I believe everybody knows it's this one. Why did he not purposely off the angle here? No, he didn't. It's just because he tried to reach primary stability and he couldn't, so he found a one socket and just placed that. Some doctor will do 2 implants, one here and the 2 implants on the molar. I don't know how to charge the patient because then there's 2 bicuspid there. But anyway, that just give a little sharing of the knowledge here. Let's challenge ourselves here. This is a very good friend of mine. He did immediate implants. As I looked at it and I asked, I know which one was immediate implants and which one was delay implants. I'm pretty sure this, and this probably delay implant. This is immediate. Why? It's because a little off angle. He sent me the X-ray before. I guessed it right. 1, 2, and off angle. So why is that? Why this doctor purposely place implant off angle? No, I don't think he purposely did that. I think he can. The design of implant and the tool, it cannot allow him to do a straight implant, so he has to go off angle. Another doctor is not off angle, is off position. And which one is off position, I guess we can guess. So I asked this doctor, give me the before X-ray. Got it. There's a single root here and no delay. Here's a huge socket, of course. He was looking for primary stability, so he went off the position on this implant, and here's the 4th one. So let's do this one. Which one was immediate implants? I believe I can't tell because they're all pretty straight. Well, all of them was immediate implants. And so why is that? Because we can change the angle, we can have a step blocking primary stability, so we can pretty much do immediate implants in a nice angulations and position. So that's what I want to try to share with everyone is a step locking concept here. So by having step locking concept, this is a knife edge, no buccal plate, this concave buccal plate right here. The implants pretty much, most of the implant exposed right out, but we're still able to reach the close to 30 Newton centimeter. So we can go ahead and temporize it, fix temporization. Let's look at this case now. It's flapless, single root. Single root is very easy. Most of the doctor knows how to do immediate implant in single root. In a single root, I came out with the spoon excavator, all these different sizes of spoon excavator. I like to have a marking on it because I do not like to waste time. When I do the surgery, I like to, at the same time, removing the diseased tissues, I will look at the markings too. So I can predetermine how long the implant. Then I can tell my assistant, get ready. For example, the socket is 11 millimeter. As I clean the socket, I'll tell my assistant, get ready with 13 millimeter implants here. So this is a single root, 2 implants placed, and both of them can reach close to 70 Newton centimeter. So of course, with such a strong stability, I can go ahead and just fill in those gaps with BioOS and fix temporary. So patient walked out with its teeth, temporary teeth. Okay, so how the laser come in place? When I'm in question with this perio-endo lesion, then I would use an Erbium laser to help me to disinfect this area much more. So by looking at this, without any functional implant, if it's a passive implant, which means the thread of implant do not get any kind of bite. Normally, we will do immediate implants in off angle now. And that's not what we want. We want the implants in a straight fashion. So with a laser and walk-in immediate implants with osteofuse, we're able, and step locking, and we can change the angle. We're able to place 3 implants in a more straight fashion. So in 4 months later, we can go ahead and restore it. Let's look at the full arch. I call it 5-in-1. Most of the people do not know what's a 5-in-1, which means the extraction, implant, sinus lift, bone graft, and temporization. So the upper arch is a severe perio. Most of them are mobility 3, some are mobility 2. So I was able to take everything out, Erbium laser remove all the diseased tissues, immediately sinus lift and implants, and also the temporization. This is her clinical picture. She came in like this the same day. She walked out with temporary, little bleeding here. Then about 6 months later, she came back. One surgery finished. 6 months later, she came back and we take impression. Of course, the anterior teeth, we use a zirconia abutment. And here's the final restoration. So she came in same day, and 6 months later, she finished. And what we did is full arch implant here. Okay, so let's talk about overheat. Most of the time we overheat the area, not just because we had to use a coolant or whatever. We still, sometimes the drill is so dull, we don't even know. So I like this one drill, one time, because there's only one drill. Just after use, we can throw away. So at any given time, this drill is very sharp. So it's lessen the overheat possibility. Now, how about sterilization, cross-contamination? Well, we're going to throw this drill away, so there's no cross-contamination. I'm pretty sure some of the doctor experienced this before. I do too. Sometimes we open up we took out the drill and being reused so many times, we don't even know, probably 50 times, we don't even know. Sometimes we take the drill out, and I still see the previous patient's bone stuck in the drill. Then I have to tell the assistant, can you clean that out, brush it off, and re-sterilize it again? So that is the little risk involved. So if we can just throw that drill away, I think we don't have a problem with that, with the infection that's going to cause. So let's go to the last, the laser-assisted Erbium laser. Many times we need this information, disease tissue removed, and we really rely on the Erbium laser. Let's look at this case now. We're going to take that tooth out, and that is an endo-perio involved. So I decided, well, I need an Erbium laser to really thoroughly clean it. We took that tooth out and Erbium laser, and I have a patient bite down. This osteofused implant has a mount, so I can really check the angulation. I liked it, and I'll go on to the second implant. After I took that molar out, the Erbium laser, I usually like to go around 3 times, just to make sure we remove all the soft bone. And not just to scrape off those granulation tissues. Soft bone usually is diseased bone, so usually we have to really bombard them and clean it out. Then after that, then here's my first drill, and which is my last drill. So just slowly, step-by-step drill right to the end where the stopper is. Then my next step is implant placement. Normally, I will put this in the RPM of close to 70 RPM. I don't like to go slow. I like to just go ahead a little faster speed on 70 RPM. Then usually I will place it halfway. Then I'll take the handpiece out, have patient bite down to double check if this is the angulation I like. And if it looks pretty good, I'll just go ahead and proceed and finish this implant. Okay, then I like it, so I just go ahead and clockwise and insert this implant in. Okay, this is before extraction, immediately, same time, same visit. This patient actually walked in that day as the first patient. She decided to have implants. We'll finish, and due to a good primary stability, I was able to put a heating abutment, and then 4 months later, we finished restoration. Let's look at another case. This is a broken root. I took this tooth out, but it looks like underneath still has a lot of infection. So to make sure to clean everything out, and as I flap it open, I realized there's a fenestration on the apical area. So using an Erbium laser, I make sure clean that area really well. I think I went 3 or 4 times, just want to make sure. And then going from the socket direction. The Erbium laser gave me a good tactile feeling, so I like that better. And also, with the water and the laser, because most of the area, these bacteria are anaerobe. So once they expose to water and the light, oxygen, I think all the bacteria are pretty much dead. So first drill went in, implant goes in, you can appreciate the torque goes almost 60 Newton centimeter. So therefore, I can go ahead and temporarily restore. Due to the reason I did a vertical incision and suture, so I use Erbium laser sometime for the bandage reason. So I think that's come in very handy here. Okay, so this patient, another patient, walk in. He had this 3 implants done, not done, still working on it for last 3 years. He doesn't know why implant takes so long, and he wants 4 implants, but so far he received 3. And he walked in about 2:30 that day. First time I saw him back in May 11. That's the first visit I saw him. In 4 o'clock, May 11, we finished these 4 implants. I'm not saying that I'm a very fast surgeon. That's not the point I'm trying to deliver here. I am not. I'm very slow, actually, but then the instruments that I'm using is so simple. So that's why I shortened the surgical time. Please keep that in mind. This is not just surgery time. This is he walked in, and with all the Q&A consultation, talk to him, talk to his wife, sign all the consent forms, then sign all the financial forms, then sit down and we do the implant. All include, it takes only an hour and a half. We finish with what he was struggling for 3 years. We finish within an hour and a half that day. So 4 months later, we finish. I try to stretch this ER time. ER time means extraction to restoration time. Why I emphasize this a lot, because most of time patient ask, how long does it take? They don't mean is if we just tell patient that it takes a year and a half and we requires 4, 5, 6 in between surgeries, I think a lot of patients will give up, will not do implants at all. So ER time is very important. It's extraction to restoration. What we have is 1 surgery to this point, no more surgery, just impression taken, and we're done in 4 months. Let's look at this patient with a laser assist VP. I call it laser VP. So walk in, ideal position, immediate implants. He's from Hong Kong. He flew in at 2:23. He walked in. I did not know he wanted. I thought he just wanted an initial exam and consultation. He walked in, talked to me, asked me many questions, signed the consent form, financial form, everything finished. Called his wife, permission all finished, and we're ready to do immediate implants. We finished laser VP at 5:47, and he came in with only 2 canines, no teeth or broken teeth. Now he has a temporary fixed. At 8 p.m. he took off and he went back to Hong Kong. After 5:47, him and I was having some whiskey because it's the end of my day and he's much relaxed. He has teeth to smile, to speak of. Okay, this is him. We did all these implants, even though they're exposed a little bit, we just bone graft, filling the void, but at least we get all the good primary stability so he can have a temporary crowns. He came back 6 months later. The ER time 6 months. He stayed in Taiwan for 10 days because we want to make sure the conclusions is okay. So we took impression the first day he landed. 1 week later, restored and checked the occlusion. 10 days after 1 week and 3 days after that, he went back to Hong Kong. But due to the pandemic, he decided when it's finished, he's going to come back for the lower. Okay, so what I'm trying to saying is with the capability of changing the angle of the drill and the implant, we're able to do all in the ideal position, all 1 arch, 6 implant. We can do 8 implants. We have a leisure of 10 implants or 12 implants as we please, or if a patient wants 14 implants, we're able to give it to them all in 1 visit. So this article has been published in JIACD. We have 6 locations and the failure rates, the survival rate, 97.2. This is one of the case, one of Dr. Alex in Las Vegas. He just learned how to do implants 2 months ago in this picture. He did pretty much a full month of immediate implants. We call it 5-in-1 with osteofuse. This patient, actually, she's very happy, and the last I heard from Alex that she had a boyfriend and she's going to get married. So that's my last case here. That's a stress about the Erbium Assist VP, okay, laser VP I call them. This is the instruments I use. Many people think I use a lot of complicated instruments. No, I do not. This is the instruments that's all I use. With this instrument, I can do simple implant, or I can do multiple implants, or I can perform oral-enteral communications. I think that is the future. We as a surgeon like to be simplify the surgery and the instruments so we can conquer the complicated cases. Okay, let's look at this case. This is 17 years ago. I did this patient 28 implants, and I guarantee him forever, which is I do keep my promise. Somehow the last implant, which is here, came loose. I don't know why. It just after 17 years, it just came loose. He came to my office. I said, no problem. I'll take the bridge off and extract this implant. So we're going to share with the last case, explant and re-implant at the same time. So with the help of Erbium laser, because I don't know the cause of this, I think it's occlusion, and I think also contributes to his smoking. But anyway, it doesn't matter. There's so many combination reasons for that implant to fail. Let's just go ahead and Erbium laser that socket very well. Then I pick up a wider drill. The design of osteofuse, I purposely designed to the point that we can take the implant out and re-implant at the same day, and the width of the design of the implant will be matching to the one that failed. As you can see, there's on the handpiece, head of handpiece, you can see there is some line here. I'm sorry. I purposely have the line because sometimes when the drill goes too deep, I can't see the drill anymore. So instead of not seeing the drill, at least I can see the line on the head of the handpiece. So I can tell the angulation. You can see there's a line here. Okay, and after using that wide drill, then I'm gonna place a wider implant at the same time. I need to get some water, sorry. Okay, so that implant goes in, and here is the extraction. And we re-implant it right away, and 4 months later, we restore. So to patient is pretty much a painless, stressless procedure. It's not so so complicated anymore, and we did not prohibit him for any function because he still can eat normally. Well, anyway, it's 50 minutes now, and thank you so much again. Happy Halloween. And for some of you like to get in touch with me, here's my email. If anybody has questions, I'd be more than happy to answer. Thank you. 喂，好了吗？喂喂。